Hello and welcome to Dental Notes and Mnemonics. Today we are going to discuss about the thumb sucking and its management. So without any delay, let's get started with the video. Thumb sucking habit can be defined as repeated placing of thumb chronically in the varying depth into the mouth. Thumb sucking is a behavior that can be grouped under the list of habits known as non-nutritive sucking, and it is one of the most common form of non-nutritive sucking. Within this group, we can also find the use of pacifiers, blankets, or sucking on other fingers as a comforting behavior. Theories has been proposed behind the thumb sucking in children. The first is Freudian theory or psychoanalytical theory, which was given by Sigmund Freud in 1905. And according to this theory, babies find comfort and pleasure through sucking because the mouth is a sensitive area. It helps them to feel safe, and especially in the first year of life. If they are stopped from sucking, they may feel stressed and develop other habits. Second theory is oral gratification theory. According to this theory, if a baby does not get enough satisfaction from breastfeeding, they may continue sucking their thumbs. This can be a way of coping with the emotional discomfort. Benjamin gave rooting reflex theory. According to this, the newborns have a natural reflex when they turn their head towards anything that touches their cheek. This helps them to find their mother's breast for feeding. This reflex can lead to thumb sucking, but usually it disappears by the age of 7 to 8 months. As per learning theory by Davidson, babies may develop thumb sucking as a habit because it feels good to them. If parents react to it, the child might continue doing it to get attention. It is not necessarily linked to the emotions, but it is a learned behavior. As per oral drive theory, if a baby breastfeeds for a long time, they develop a strong need for sucking. This can make them continue thumb sucking even without emotional reasons. Based upon the theories we have learned so far, we may categorize the causes of thumb sucking as a natural reflex or the primitive reflex. Where it starts as an early or primitive reflex, it helps babies with feeding and provides a sense of security to them. Also, some children use their finger as a teething device during the period of eruption of primary teeth. Thumb sucking also provides a sense of self control and safety to the child, especially in stressful conditions. Emotional distraction, cruel behavior with child or punishment, or imitation of others. Thumb sucking provides a sense of self comfort and safety to the child, especially in stressful situations. Through repetition, thumb sucking can become a habit. Over time, children associated with comfort and continue even when they no longer need it. Thumb sucking is the most common between the ages 2 and 3. Most of the children outgo this habit by the age of 4, but some may continue longer due to psychological or other environmental factors. Family dynamics and parenting can affect how long thumb sucking lasts. Loving, stable environment reduces the need for prolonged thumb sucking. On the other hand, stress at home can make the habit persist longer. Children from poorer backgrounds often have to nurse for the longer period to receive the adequate nutrition, thus they have more tendency for thumb sucking. If we compare urban versus the rural children, then researchers have suggested that thumb sucking is more common in industrialized urban areas than in rural areas. This may be due to differences in the lifestyle, feeding habits, and the parental involvement. Number of the siblings also affect the thumb sucking behavior. In families with many children, parents may not be able to give equal attention to each child. This lack of individualized care can lead to emotional distress, increasing the likelihood of thumb sucking as a self-soothing mechanism. If a newborn is breastfed for less than 6 months, there is fourfold chance that an infant may develop a non-nutritive sucking habit. Genetic and environment both influence thumb sucking in children. Some children may have inherited tendency for self-soothing behaviors. Let's discuss the effect of thumb sucking and its pathophysiology. Thumb sucking can be characterized by frequency, intensity, duration of the habit. The duration of the force in thumb or digit sucking is more critical than its magnitude, and the resting pressure has greatest impact on the position of tooth. Thumb sucking can lead to dentoalveolar and skeletal malformation. Thumb sucking affects various parts of the body, including fingers, lips, facial structure, dentition, speech, and tongue. The thumb appears reddened, smaller, and clean due to frequent sucking. There is also callus formation, which is a fibrous, roughened texture, and groove formation on the thumb, which gives the thumb a dishpan appearance. Upper lip appears weak and short due to hypotonicity, and the lower lip becomes hyperactive due to overactive movements. Due to this, the lips become incompetent. That means the patient is not able to close them properly to make perfect oral seal. Before going into the effect of thumb sucking on the hard tissue, we should be aware of the buccinator mechanism. In normal oral environment, the buccinator plays an important role in maintaining cheek tone, preventing inward collapse of maxillary arch. The tongue rests against the palate, supporting proper arch development. With balanced lip tone ensures normal muscle functions, and this balance allows for normal transverse maxillary growth and a well-developed occlusion. But when a child habitually sucks their thumb, several changes occur in the oral musculature. The thumb blocks the tongue from resting against the palate, forcing the buccinator muscle to contract excessively in attempt to compensate. This increased cheek pressure applies inward force on the maxilla, leading to a narrow maxillary arch and ultimately a posterior crossbite. Additionally, the lack of proper tongue pressure on palate prevents normal palatal expansion, resulting in deep and high palatal vault. The negative intraoral pressure created by thumb sucking disrupts a normal tongue posture. The tongue remains in a low position, causing the upper incisors to flare forward, a condition known as proclination. Additionally, thumb placement weakens the upper lip while making the lower lip hyperactive, lead to an anterior open bite and an increased overjet as well. Prolonged thumb sucking can lead to skeletal changes as well. In the normal development, facial growth follows a downward and forward pattern due to coordinated maxillary and mandibular growth. The maxilla grows transversely, anterior, posteriorly, and vertically with proper tongue pressure promoting maxillary arch expansion. The mandible follows a counterclockwise rotational growth, ensuring balanced occlusion and harmonious facial profile. Lip and buccinator muscle activity remains balanced, supporting normal dental alignment and occlusal relationship. But in case of thumb sucking, the facial growth pattern is disturbed. In maxillary arch, the maxilla experiences constricted or restricted transverse growth due to increased buccinator muscle pressure, leading to posterior crossbite. Upper incisors proclination can be seen, leading to convex facial profile. The palate becomes high and narrow, affecting nasal breathing. The mandible exhibits retrusion, contributing to skeletal class 2 pattern. Lower incisors become retroclined, worsening overjet. Decreased muscular activity in the lower jaw alters the mandibular growth trajectory, leading to an open bite. Increased lower facial height due to an open bite, and mandibular plane angle increases, leading to a long face syndrome. The altered tongue posture fails to support normal posterior facial height development. If we talk about the effects of thumb sucking on interarch relationship, then thumb sucking causes overjet, increased overjet, open bite, and posterior crossbite, leading to difficulties in biting and speech development. Thumb sucking exaggerates convexity in the facial profile, making the chin appears weak and the nose more prominent. This can lead to long-term aesthetic and functional concerns to the patient. Speech is also affected in patients with the long-term habit of thumb sucking. We can find the articulation disorders, pronouncing certain words like S, Z, sh, ch, t, or d. Anterior open bite prevents proper contact between the tongue and teeth, affecting speech clarity. Let's discuss the management of thumb sucking, and we'll discuss this topic under three headings: preventive management, interceptive, and corrective management. Starting with the preventive management for thumb sucking in children age 0 to 3 years, focuses on natural cessation of the habit. Parents should be informed that it is normal and often resolves on its own. Providing emotional security, reducing stress, and offering alternative comfort methods like soft toys can help. Instead of punishing, positive reinforcement should be used by praising the child when they avoid thumb sucking. Engaging the child in activities that require both the hands, such as playing with toys or finger painting, can serve as distraction. Thumb covering is a preventive measure for thumb sucking that involves using physical barriers to discourage the habit. Method include applying bandages, gloves, mittens, or thumb guards, which act as a reminder and make sucking less satisfying. These coverings should be comfortable, breathable, and safe for children, ensuring they do not cause any irritation. Interceptive approach for thumb sucking includes behavior modification, habit reminder techniques, parental counseling, oral appliances, and myofunctional therapy. Behavioral modification involves positive reinforcement such as sticker charts where the child earns a reward for each day without thumb sucking. Habit reminder techniques such as gentle deterrents like bitter tasting nail solutions or bandages, which make thumb sucking less appealing. The technique involves chemical and mechanical methods. In chemical methods, these involve applying safe, pediatric approved bitter tasting solution, for example, the neem extract or the commercial bitter nail polish on the thumb. The unpleasant taste discourages thumb sucking. And mechanical methods involve applying the physical barriers like bandages, thumb guards, gloves, or orthodontic appliances. Myofunctional therapy helps retrain oral muscles and tongue posture. For example, a child can practice holding a small button between their lips to strengthen lip seal and reduce the urge to suck their thumb. And oral appliances like palatal crib may be recommended if habit persists and starts affecting dental alignment. By the age of 6, the permanent teeth begin erupting, and prolonged thumb sucking can cause serious dental, skeletal, and speech issues. Behavioral reinforcement alone may not be sufficient at this stage, making orthodontic appliances like palatal cribs necessary to physically prevent thumb placement. Orthodontic treatment needs to be started when thumb sucking has caused significant dental malalignment such as open bites or excessive overjet. Expansion therapy using devices like rapid palatal expanders is effective in correcting a narrow maxillary arch and crossbite in growing children. In cases where the skeletal discrepancies persist into adulthood, orthodontic surgery may be necessary to correct the severe open bites, jaw malalignments, or facial asymmetry. Palatal crib is the orthodontic appliance which is given commonly for thumb sucking control. It consists of cribs vertically disposed, extending from the palatal region completely covering the anterior open bite and resting close to the gingival area, lingual to the lower incisors when the posterior teeth are in occlusion. It serves as a complete mechanical barrier to thumb or finger. Palatal rake is similar to palatal crib but have smaller prongs that create discomfort when the thumb is inserted, making them more suitable for older children with persistent habit. While cribs work passively by eliminating the pleasurable aspect of thumb sucking, rakes actively discourage the habit through mild irritation. Bluegrass appliance given by Haskell. This design consists of a modified six-sided roller which is made up of Teflon to prevent injury to tongue, and this roller is slipped over a stainless steel wire which is soldered to molar orthodontic bands. This appliance is placed for 3 to 6 months and instructions are given to turn the roller instead of sucking the digit. As we have already discussed that thumb sucking if prolonged, can lead to narrowing of the maxilla and thus can cause posterior crossbite. So this can be corrected by using the expansion appliances. The expansion may be slow or may be rapid. The slow expansion appliances like quad helix, W arch, lingual arch gradually widens the jaw over the period of time with a gentle pressure, taking several months for the noticeable changes. These are used for controlled steady expansion. On the other hand, rapid expansion appliances such as rapid palatal expander and has expander uses a screw mechanism to quickly widen the jaw, often achieving the desired results in just a few weeks. Rapid expansion is typically used when faster correction of narrow upper jaw is needed, especially in the children with more severe crowding or bite issues caused by thumb sucking. In the end, I would like to quote that habit control is mandatory. Even after orthodontic treatment, if we have not controlled the thumb sucking habit of the patient, then there would be relapse once the case is debonded. Please go through the flow chart for better understanding how does malocclusion develops due to prolonged thumb sucking. So this was all about thumb sucking, its effect and the management. Hope you liked the video. Don't forget to subscribe to the channel and see you in the next video. Till then, bye bye, take care, have a nice day.